Good afternoon. This is Delaine Henry, the CEO of Advanced Hospice Management. I just would like to give a couple more minutes. We have several attendees who are in the process of signing in. I just wanted to let everyone know we were here and ready, but I'll give them a couple of minutes and then we'll get started. Thanks, you guys. Good afternoon. This is Delaine Henry, CEO of Advanced Hospice Management. We have a pretty long presentation today, and in the interest of time, I'm going to go ahead and get started. So again, let me introduce myself, and my company here is Advanced Hospice Management. We are a full-service, hospice-only, third-party billing solution. We are geographically dispersed, which means we service customers across the country and also in Puerto Rico. We have a full team of highly experienced and educated billers. We are trained to maximize your collections, and we really focus on collecting your hard money. So if you guys have any questions or challenges with regards to billing, please don't hesitate to reach out to us. If there's any way at all that we can help, we are happy to. So today, I think our webinar and our newsletter are linked, and our newsletter went out with the proposed rule for hospice for 2019. But there are a couple of other topics that I would like to cover today because they have, become part of the issues that we're dealing with hospice billing. And one is this Mbi Alert, which everyone knows by now that the Medicare program is giving all of the Medicare beneficiaries a new identifier number. So as opposed to using their old HIC number, which was their Medicare number with a letter, either prefix or suffix, they've now issued these random Medicare beneficiary identifiers. And there's been some issues with how the Medicare beneficiary identifiers are being displayed on the DDE system. So there was an issue back in May where claims that were submitted for processing with the old HIC number were being displayed in DDE with the new MBI. And I believe that was supposed to have been resolved as of 5/29. We have not seen any of these issues, but I just wanted to point out that if anyone is having a problem with finding claims on the DDE system and they're not being able to pull a claim based on the Medicare number, that maybe it is because it is linking it to the new MBI for that patient. So you may want to double check that. Also, there are some issues with using the MBI prior to the patient actually getting their new Medicare card. And there's been several issues since the beginning of the issuance of these cards because not everyone is receiving their card at the same time. However, we've noticed, and I'm sure a lot of you guys have noticed as well, that when you bill for a patient with their HIC number, the old number, when you get a remit, you're getting the new MBI number notated on that remit. So a lot of agencies are entering that new MBI number right into their system and doing future claims with the MBI number. But Medicare is asking that we don't bill with that number until the patient has physically received their card in the mail. And you can look them up on the new portal using that card. And we want to make sure that those things are in place prior to billing, because there's some disconnect in the common working file between claims that are linked to the HIC number and claims that are linked to the MBI. So we just don't want to jump and use the MBI prior to the patient receiving the card. And keep in mind that the Medicare Beneficiary Identifier lookup tool is live, and this is the link, and we will send out the full slideshow to all attendees, so you'll have this information and you can jump into that system and verify the MBI for your clients there. So again, we don't want to bill with that MBI until the patient has gotten their new Medicare card. So we're going to cover the proposed rule for hospice for 2019. This is CMS's proposed rule. And there are several things that we'll talk about today. I believe there are some, it's a pretty large document, but we're really focused on how it affects hospice, how it affects billing, and how it affects reimbursement. And of course, we know HIS and quality reporting can affect reimbursement if you are not submitting your data timely. So we'll touch on that as well. So the proposed payment update percentage for FY 2019 is 1.8%. However, it's distributed differently across the country, and that's attributed to variation in wage indices. CMS estimates a range from a high of 3.3% to a low of 1.4% increase depending on geography. The proposed hospice cap amount for the year will be $29,205.44, which is equal to the 2018 cap amount with the updated 1.8% increase. This is a table that gives you the national rate for all the level of cares and the 2018 rates versus the proposed 2019 rate. Following the fiscal year 2016 updates to the hospice payment system, CMS has continued to monitor data related to those changes. The analysis data is expected to impact future refinements to hospice payment rates. So there were some issues that Medicare has brought to our attention in the past, and I'm going to go into a little more detail on about 3 of those things. And basically what they're asking for is feedback on those, but they're pointing out that they are still seeing issues in some of these areas. And I think it's important to note that they are analyzing the data that they're receiving on claims, and they're looking specifically at these issues. So the first one is service intensity add-on. So we know that CMS identified that patients were not necessarily receiving a higher level of skilled care or a more frequent level of skilled care during the last days of life, and they implemented the service intensity add-on to create, the objective of encouraging skilled visits at that critical time. But according to CMS, since that implementation of SIA payment add-on, they have not seen an increase in visits during the last 7 days of life, and they feel that the SIA is being underutilized. So I think that's important to point out. Obviously, you would not want to provide care that's unnecessary, but Medicare has identified that point of a patient's care, the last 7 days of life, as a critical care need. So they're encouraging us to see the patient more. We wouldn't want to abuse that. Obviously, that's not the case. They don't feel we're using it enough. And again, we all know that it's impossible to know when a patient will die, and we try to provide care based on the patient's level of need and decline. And I think because of the hospice benefit and because of how clinically we assess our patients, and we should be able to identify decline, that should prompt a higher level or a more frequent level of care. And I think if CMS doesn't see the SIA visits being utilized, that may impact us in the future in ways that we can't yet predict, other than to think that maybe they will add some QRP measures to ensure that the patient is getting an appropriate level of care. And we don't know what other refinements may come as a result of SIA and its underutilization. Another area of concern, and this is something we've discussed before, and I know there's been a lot of discussion between CMS and Medicare Part D regarding the ongoing expense that Part D is paying for drugs for patients that have elected hospice. So Medicare, of course, says that hospice should be covering drugs that are related to the terminal condition and any related conditions. And they are still seeing a large expense of drugs that are going to Part D for reimbursement as opposed to being paid for by the hospice. So CMS reminds us again that the hospice is responsible for covering drugs and biologicals related to palliative care and the management of the terminal illness and related conditions. So Part D should only cover drugs when it is clearly for treatment unrelated to the terminal illness or related conditions, and that should be a rare occurrence. So Medicare, again, is comparing the Part D drug expense and linking that back to hospice beneficiaries and seeing that there's a lot of overlap still, and that expense for Part D should be reducing. And while it is, I don't think it's reducing at the rate that they feel it should be. So we definitely want to be sure that patients are not filling prescriptions without the hospice's knowledge, which sometimes could be the case, or that the hospice is maybe not covering all of the drugs that the patient is taking, and therefore they're filling it at the pharmacy with Part D. The final concern for us was cost reporting, and that is in the 2016 rule, they expanded the data collection on cost reports, and CMS, through examining cost reports and also through a provider feedback, they've discovered that there's quite a lot of information that is still being excluded from the cost report, and they're still looking for ways to improve and increase the submission of high quality data on the cost report. So I don't feel like they think they're getting the data they're asking for, and maybe they're not sure they're asking for all the data they need. So we can probably look for more expanded cost report requirements. Reducing agency burden. This was something else that Medicare asked for feedback on over the last few years, about what can they do to reduce the burden, unnecessary burden on hospice providers. And of course, one area was drug data. When it was implemented that we had to provide line item drug data specific with NDC numbers and fill amounts and all of those new line items required on claims, providers indicated that it was a burdensome process for them to gather that data and get it into their system, get it onto their claims. So as a result, CMS is proposing to remove the requirement that we have specific line items for each drug. So now they're giving us two options, assuming this goes to final rule, which I'm pretty sure it will, that we will be able to either continue doing it the way we're doing it now, which is a line item for each drug with the NDC number and all of the data we're providing, which obviously I think at this point, everyone who works in an EMR or software system has probably figured out with their pharmacy the electronic way to get that file from your pharmacy and into your EMR system. So most providers have already worked this out because it's been a requirement now for so long. So if you're already doing that and it's working, they're saying you don't have to change it. But if you're not doing that, or if it is burdensome, the process to get it into the system or however you're getting it to your claims, they're proposing that we will be allowed to have a one line item total for drug charges and DME. So I'm not sure if backtracking really is less burdensome if your process is in place. But at this point, if this proposed rule goes to final rule, we will have the option to do those drug reporting data either way. They're also proposing in the 2019 rule that they give us a new HIS correction deadline, and this is for correcting data, not for submitting data. So we want to make sure we make that distinction. You still have a 30-day data submission deadline, but they're saying that they are proposing to give us 4.5 months after the end of each quarter to make corrections to your HIS data. And that's really important that you guys are looking at your data on Hospice Compare and looking at your reports and making sure that the data that Medicare is reflecting is accurate. Physician's assistants can be attending hospice physicians. So this actually is part of the Bipartisan Budget Act of 2018, and Medicare will begin to pay for medically reasonable and necessary services provided by PAs to Medicare beneficiaries at a rate of 85% of the fee schedule for the amount of the services, which is the same as it is right now for nurse practitioners. So they'll make the rules, they'll change the hospice care regulations to meet this Budget Act rule that will allow PAs to now be attending physicians for hospice patients. However, it did not change or expand which practitioners can certify terminal illness or face-to-face encounters. So while your PA can be your designated hospice attending physician, the medical director or the physician member of your interdisciplinary group will have to certify the patient with terminal illness and perform your face-to-face visits as required. MLN matters. So that is everything regarding the proposed rule that we wanted to cover. I know that that's not as in-depth, but we are trying to focus on the billing and the reimbursement impact that it may have. But this MLN Matters SE 18007 was published on 6/7, and this is directly related to hospice billing. So I felt like we really wanted to present this, and even though we may not present it in its entirety and in as much detail as I would like to because of time, I believe we will re-present this next month because I have several questions in to Palmetto GBA and to NGS regarding this document, and I'm hoping to get some detailed response that I can share with everyone. So this document is a hospice-specific document, and it's related to the improvements that were made prior, and it's also related to some new improvements that start just next week. So we'll talk about those. So recent improvements as of January 1, I'm sure you guys remember we presented this in December if you attended our webinar. Medicare has given us an electronic NOE submissions option using EDI. So they've created a claims format where notice of elections can cross over electronically from your software system to the Medicare system on an 837 claims format. They also gave us a way to correct elections and revocation dates using Occurrence Code 56, and they gave us a way to remove revocations that were submitted in error. Now, I'll tell you that for us, we've been able to electronically submit NOEs, we've been able to correct NOEs and revocation dates, but we have not been able to remove revocations using the directions. And we've confirmed with at least one MAC that they can tell us why it doesn't work. They can't tell us what to do to make it work, so we're still having that problem. So again, before January 1, you could only submit notice of elections by hand keying them or on paper. You were a small agency. And because the hospice industry really pushed to have an electronic option there, Medicare gave us one using EDI, and it has helped to eliminate potential problems and errors with hand keying. And it allowed hospices to export data from their EMR, so that makes us more productive as well. So the upcoming improvements that will start on July 2nd, just next week, has taken Medicare 2 years to develop for us. And what this does is it redesigns the hospice election and revocation information, and it separates it from the benefit period information. So those two separate sets of information will now act independently. And this is a lot of information. I've only read it about 20 times, trying to make sure I understand it accurately. So if you have questions, please don't hesitate to ask. And again, I have questions into my contacts at Palmetto GBA and at NGS, because even with this document, I still have questions. So I'm not sure that I can answer you, but if I can't, I will find the answer for you. So the new election periods in the Common Working File will have a separate screen. They're going to add a screen to our Common Working File. When we look up a beneficiary right now, we have one screen that shows you benefit periods, admit dates, elections, whether or not the patient has revocated or not. It's all on one screen. Starting next week, it will be on two screens. So we'll have one election screen and one benefit screen. And the difference is this: your elections are going to be determined by, of course, your notice of elections and your NOTRs. Your benefit screens will be predicated on claims. So it will your benefit periods will be created and terminated by your claims data. So that will make it look different. So you'll have two screens again, and they're going to convert all existing hospice benefit periods if the periods are 4 years old or less and there's no revocation, they are going to transition those elections to 2 screens. So all your patients that you have currently, when you go into the common working file on Monday, you will see the 2 screens, and all that election information will be separate from the benefit information. I'm going to try really hard to explain this. There's just a lot of information, and I don't want to confuse anybody. But again, on some of this, I actually have questions. So the redesign of the common working file hospice information will have the following benefits. It will reduce NOE timely filing exception requests by providers by ensuring benefit periods can be canceled without removing the NOE receipt date. So if you have an agency who requests that you back out your billing so they can bill because of sequential billing rules, you will now be able to back out your claims, which will remove your benefit period, but it will not remove your election date. So that's huge. It will allow NOTRs to be submitted at any time rather than only when a benefit period covering the revocation date has been created by claim. So we will no longer have to wait for a claim to post in the common working file to file an NOTR or file our final claim with the discharge or revocation indicator, because we cannot file an NOTR because there's no existing benefit period. So the election periods and the benefit periods, again, are separated. So we can file an NOTR at any point, even if we have never filed a claim on the patient, as long as we have an open election. This reduces the workload for providers when reprocessing periods by automatically removing benefit periods when all claims in the period are canceled. So this just prevents us from having to file an 8-1D for each benefit period that we used to have to do in order to remove those benefit periods in a claim segment. It enables easier implementation of future policy changes. So this will allow Medicare to make changes or policies or processes related to elections or related to benefit periods. It will not have to be related to both. So again, this is just saying exactly what I said, that the hospice submission, that when the hospice submits the NOEs, Medicare system will create an election period, and that is separate from any benefit periods. And you'll be able to view those election periods on a new page in DDE, which will look like this. So your election date, your election screen will only have your election date, the receipt date of the election, and then the revocation date. So these are basically admit, discharge, and that receipt date is showing that you filed your NOE timely. So that's how your periods will show on your common working file on the new election screen. And I'm sorry, I do not have the current benefit screen. I don't have an example of that. But what I would like to do is pull up this SE 18007. That's the MLM Matters that gives us all of this information. It's really an in-depth, it's 10 pages long. It tells us what they changed on January 1, and then it tells us what will change upcoming. And let's see. Okay, so this is the MLM Matters, and again, I'll make sure all attendees receive this. I'm sure you guys have gotten it. But I'm going to just run through it really quickly, and if you all have questions, please ask at the end, and I'll go back to anything I can help explain. And if I don't know, like I said, I will be happy to ask my contacts, and I already have a list of questions in because I want to be sure that I completely understand it. So the recent improvements I already covered in my slides. Some of this I condensed on the slides all the way down to page 5. So all of this just reiterates what they did January 1 in detail. So if you have questions about correcting an NOE date or an NOTR date, you can go back and review the first 4.5 pages of this, and there are examples to make NOE and NOTR corrections. But again, removing an NOTR, that process that they've given us has not worked for us. If it works for you guys, I would love to hear it. This is the part I'm talking about. If a revocation date was submitted entirely in error, like if you were supposed to transfer a patient and instead file a revocation, they're telling us to submit the type of bill 81B with zeros in the through date, and it will not accept that claim. And we've called Palmetto, and they haven't been able to instruct us on what to do to correct that, or if there's a process we should be using that we're unaware of. They couldn't answer those questions. So upcoming improvements, these are the slides that I've already covered about what they're doing to separate the elections from the benefit period. and this is the screen that we just looked at. So this is going to be our new election screen that shows admits and discharges. So I'm going to try to just cover some highlights from this page forward. Like I said, it's a lot of information, and I don't want to keep everybody. I know everybody's super busy, but I think it's super important for billers to understand this because it does change a couple of really important processes for what we do now with regards to particularly NOTRs. So I'm going to start with, so we talked about benefit periods. Unlike in the past, the 81A will not create a benefit period, it will create an election period. Your claims will create your benefit period. Hospices will no longer need to submit the void cancels in order to remove benefit periods. We talked about that as well. So those will automatically go away when you cancel claims. When you submit an NOTR, it will post the revocation date on the election period page with the revocation indicator 1. And it will, if you file a claim with the discharge, it will also post a revocation, and it will terminate your election date. So you can do either. And that's what's stated here. If the hospice files the discharge claim in lieu of the NOTR, the claims will be posted and the revocation date and the revocation indicator on the new common working file election period screen, in addition to the updating the term date of the benefit period, will match the revocation date. So that the claim will still terminate your election period if it indicates a revocation or discharge. Okay, NOTR submission changes. So when there's no change in the provider number during an election, this is really important. So right now, when we file an NOTR, which is an 81B, to revoke or discharge a patient, we file it using the start date of the most current benefit period and the termination date. So it's a from benefit period, in termination date. Now we will file it from start of care if the patient was not a transfer from another hospice. So we admit the patient directly to us, not a transfer. We will use our admission date through our revocation or discharge date on that NOTR. And that's a change from what we're doing now. And it's important that we get these dates correct. So if the patient was a transfer and now we're doing a revocation, we use our start date 2, which is our admission date, the incoming transfer hospice, to discharge. So that changes the dates we currently use on NOTRs. And I'm hoping this is not really confusing. I've explained it a couple of times, trying to do it in the most concise way, but it's just a lot of information. So we will continue to use 81Ds to remove election periods, to remove a transfer that was submitted in error, or to remove a change of ownership that was submitted in error. As with NOTRs, hospices will need to be careful with the from date on the 81D in order to remove the correct information. So it's the same issue. You want to make sure you're using your election dates and not your benefit period dates when you're filing 81Ds, just like when you're filing NOTRs, which are 81Bs. So processing impacts. Today, if a benefit period exists for a beneficiary and is not revoked, another NOE can be accepted for a later date as long as it doesn't fall within the last election period that the previous hospice has established. So in other words, if a hospice is billing a patient and they haven't completed their billing, but the election period, or the benefit period, that is currently established by their billing has ended, we could actually go in and file a notice of election and block their billing, so to speak, and that election would process. So now, with the new changes as of July 2nd, that will no longer be the case. Even if an agency has an open election period and they haven't billed in a while and they don't have a current established benefit period, if they have not filed an NOTR or they have not filed a final claim to revoke and there's no revocation indicator, a new notice of election will not process. It will be rejected with reason code U5106. So it's going to become even more important that we follow our 5-day rule for NOTRs. We know that there's right now no penalty for not filing your NOTR timely, like there is for not filing your notice of election timely, but because we are no longer going to have the constraint of an open benefit period, Medicare will expect us to have those NOTRs filed within 5 days, and there's truly no reason why they shouldn't be. So we want to be certain that we're keeping up with our NOTRs just as diligently as we keep up with our notice of election. So this is a summary chart that shows you how the election periods, what the effects are on your election periods and your benefit periods when you file these types of elections. So you can go through this chart and look at what happens when you file a notice of election, an NOTR, transfer, a void, or a change of ownership, and of course claims. And that's just kind of a summary chart that tells you what the new impact is on the separation of these two election periods and benefit periods. So I know I covered a whole lot of information there in a very short period of time. So if you guys have questions, please don't hesitate to ask. I'm opening my question box now if anyone has anything. Again, I'm going to send this handout out with our slideshow. So all attendees will receive this, and maybe once you all have had a chance to read through it in a little more detail and make notes and ask questions, then we can get some feedback on it. I would love to know, what you guys think, if you have any questions at all. Also, like I said, I've already submitted questions to a couple of the MACs, and I'm hoping for some detailed clarity responses on some of this, because while some of it seems to be really clear, there are questions, and for me the question is, they indicate that your notice of election will remain on the election page even if you've backed out all of your claims for another hospice to bill. So therefore your election hasn't been removed, which means to me that you will not have to file the timely filing, disputes or appeals, and you will no longer have to appeal those claims when you re-enter those for repayment. So those impacts, of course, are huge on our revenue, and that will make claims move a lot faster. That eventually, this, if it works as it should, as it appears to be set up, within a year, we should no longer have issues where we would be asked to remove claims or back out claims for another hospice to bill, with the exception of newly certified agencies that you were unaware were part of the hospice care for a patient that you may have on service. So this will eliminate a lot of those issues, which is great news. I'm sure you guys have all experienced having to back out a significant amount of money in claims in order for another agency to bill. And I can see that this process, if it works as it should, will greatly reduce that. So I don't see that anyone has asked any questions, but that's the end of our presentation today. And again, I will re-present this in July with the additional information I received back from the MACs. And I will include a few of our own breakdowns on some of these processes that might make it more clear about the impact that this election and benefit period split will have. And I'm hoping that the impact is what I think it is, and I'll be able to confirm that by our next call. So I hope you guys will all join again, and we'll go through that. And I hope everybody has good questions. I hope you've learned something from this, and if there's anything at all that we can do, please call me, email me, ask the question here. Whatever we can do to help make this more clear, we're happy to help. So thank you guys for joining us. Again, I'll pull up the slide on our last, let's see if I can make this work. So my contact information is on the last slide here. There's my email. TJ Henry is our COO. There's his email. Our number to our office, again, if we can answer any questions, or if you have questions in general about billing, if you need help, if you're having challenges with regard to Medicare or any other type of billing, please reach out to us. We're happy to help. So thank you all for joining us. Have a great afternoon, and we hope to see you again next month. Thank you. Bye-bye.